Hello, everyone. Good afternoon to you. The subject is death. Does that make you a little bit queasy? I will not force you to think about your death. The slide says choose one for yourself. Well, if you are rather uncomfortable about thinking about your own death, think about mine. Human mortality continues to be 100%. We will all die someday. I know I will die someday. I have only about 10% chance of dying a sudden death. It is very likely, therefore, that I will be bedbound for a period of time, be seriously ill before I go. About that time and about how I go, I do have some thoughts and some wishes. You see the picture. On one side is the humblest of the humblest, a woman in a destitute home with cancer who did get some palliative care, and though we had to raise money to bring the daughter away from her village, the daughter and mother were together, and towards the end, when the woman had parched throat, the daughter could pour a few drops of water down that throat. In short, I believe she died with dignity. Look at the other panel. Here is how most of the people who are watching this show will go, because you all have some money in your pocket, you are likely to go to a good hospital, and the way things stand in Indian corporate world, most people die in this fashion. Death is medicalized. People are shifted to intensive care units when their oxygen concentration drops, when your sodium concentration drops, when your potassium concentration becomes abnormal, or for a lot of reasons. Listen, no one can die unless it's a sudden death with a normal oxygen saturation and a normal sodium concentration. It's the process of dying. As your cells lose the energy availability, as the ATP gets depleted, the sodium pump fails. Sodium becomes more intracellular. The extracellular sodium has to drop. The way we treat it today, even in the incurable context, even when it's apparent to everybody around that the person is dying, they are still shifted to an intensive care unit. Multiple attempts at peripheral vein cannulation will cause pain. Eventually, a cannula will go into the neck. And when the person's breathing becomes inadequate, a tube goes down the throat. Your airways are possibly the most sensitive part of the body. A doctor who had an endotracheal tube while conscious told me that every time a suction catheter went in, it felt like an iron rod being pushed into your body and twisted as it is withdrawn. It's that bad. And we subject people to that kind of horror. Look, I am an anesthetist by training. I was an intensivist. I know that intensive care can, in a salvageable situation, can work miracles. But if somebody is dying of an incurable condition, say from advanced cancer or some such problem, then this becomes a mockery. It violates human dignity to the extreme. It inflicts untold suffering. And among other things, it separates the family from the person. When my time comes, if one of you is looking after me, I have one humble request. Please do not imprison me inside your air-conditioned torture chamber, which is so expensive to my family. Allow me either to be at home if the medical system can give me some support, like possibly in a Western country, but if that's not possible, allow me to be in the ward or in the hospital room. Let the family stay with me. When I go, if I have a choice, I may want to give a final message to my wife. If I am feeling scared, I may want to hang on to my son's hand, and I may have this desperate wish to get a kiss on the cheek from my grandchild. These are the most important things for me at that time, not the hypertonic saline infusion or the ventilator or the expensive gadgetry with about a dozen alarms screeching all around me, no difference between day and night. And you know that I know that 2/3 of the elderly getting into an ICU get delirious. That delirium is often associated with unpleasant dreams and hallucinations, and it can be the most fearsome experience. What's the rationale? Why do we do this? We know that such futile and inappropriate artificial life support measures cause not only the physical pain and agony, it doesn't satisfy the emotional needs, it causes social suffering. My family is likely to live with guilt about not doing justice to me. And despite all this, we continue to do it. Why? For one thing, it is true that the legal situation is confusing. We do not have a law covering this situation. And therefore, doctors are often afraid of litigation. But I sometimes think, even more than that, there is a feeling among doctors, especially young doctors, that they have a duty to keep the heart going as long as possible. Do we have that? When I was a medical student, I was told that a doctor's duty is to cure sometimes, relieve often, and comfort always. This is a 14th century aphorism, still valid. Our duty is to cure sometimes, certainly whenever possible, but to comfort always, relieve suffering as much as possible, and to comfort always. But especially in the last half century, with the growth of technology, with the advent of critical care, today's doctors feel they have to keep the heart going. I don't know if anybody has written the article in the late press written by Mr. Parthasarathi Show, the financial advisor to the previous Prime Minister of India. He writes about his mother's treatment. And when everybody around was sure that the mother was dying, he found somebody poking a needle into his mother. They're checking their liver function. He asked why. The doctor said, we have to keep trying. Trying to do what? We have become a death-denying society, particularly the medical professionals. Death is the inevitable consequence of life. And you have a duty to make sure that if I am your patient, you allow me to live with as much comfort and as much dignity as possible. But even if you recognize that right, and even if you are not afraid of the law, very often we find that unfriendly hospital protocols force doctors' hands. Sodium below 128, he has to be in an ICU. Potassium below 3, he has to be in an ICU. Saturation below 90%, he has to be in an ICU, even if the person is surely dying. Now, it's also true that it's not only the doctors. The families keep on wanting to give life support measures, even when they know that the situation is not salvageable. That's possible usually because we do not help them to accept the inevitable consequence. Death is a stranger to today's, especially today's city dwellers. They don't see death. They don't see animals dying in the shed. They don't see grandparents and uncles and aunts dying. And of course, to a lesser extent, it's also social pressure. Even if somebody, it happened to several people whom I know. The family sat together and the man or woman expresses the wish, I want to die at home. The family agrees. Then comes an uncle, needling the son or the daughter. Hey, you are keeping him here? I see. You don't want to spend money on your son, father? Is he not your own father? Questions like that. The infliction of torture, unintended perhaps, but the social pressure today to medicalize death is significant. So these are all realities. But despite all that, remember, I have a right. I have a right over my own life. And I, by our Constitution of India, I have a right to life with dignity. When I am dying of an incurable disease, if you incarcerate me in intensive care unit against my will, you are violating my fundamental right to life with dignity. Only thing is, I cannot go to court anymore. I am too weak. Now, it's also true that sometimes there's a confusion between euthanasia and withdrawing an artificial life support measure. Now, this is universally accepted in international professional circles. If you look up withdrawal life support on Wikipedia, that's not reliable. But it's universally accepted that in euthanasia or physician-assisted suicide, there is an intention to cause death and an intervention to hasten dying process. In physician-assisted suicide, the doctor is still connecting up the infusion and allowing the patient to open the tap. There is an intention to end life. Withdrawal of an artificial life support measure like stopping a ventilation is not intended at killing somebody. It's so intended only at allowing natural death. You know that the person is closing down death and you allow it to happen. This is a very clear distinction. We need to get that very clear. Withdrawal of life support is not euthanasia. It is only allowing natural death. And as I said, you have the duty to respect my autonomy. This is the fundamental first overriding principle of medical practice. Because I have expressed this wish to you that I want a natural death, not a medicalized intensive care death if I have a choice. You do not have a right to decide more than I. Now there are, though we do not have a law, there are several documents which help us to distinguish between euthanasia and withdrawal of life support, like the 196th Law Commission report of India, which also gives guidelines about how to withdraw life support, but that is not the law, granted. But in the absence of a law, another resource to fall back on is the Medical Council of India's report. Now, Medical Council of India also has given recommendations for management of terminally ill patients. And they say the patient should not be unnecessarily kept on modern and expensive life care support system. And they go on to recommend that if the person has kept a living will, go by it. I have written my own living will, otherwise called advanced directive. I have written it, I have got it witnessed, and not only that, I have intimated that to my family and obtained their consent. Even if I have written it down, If they object, I know that my wish will not be granted, but my family has consented. But suppose the person has not left a living will, then naturally one will have to go by the wishes of the next of kin. Now, right at the moment, the government of India has proposed an end-of-life care law. We need that, true. But even if we have that law gets passed, the Supreme Court of India asked the Parliament to decide. They said, let the people's court decide. But even if the Parliament passes the law, this is not going to change overnight, because it's not only a matter of law, it's also a matter of medicine and ethical practice and doing justice to the dying, which is why you and I have to talk about that, not only among ourselves, but also to the public. Death has to be accepted as the consequence of life and has to be a subject of conversation, so that we are not so totally scared of it that we don't talk about it and then find ourselves being tortured in the ICU. Now, how would we manage that? Instead of immediately thinking, let us intubate that trachea, let us improve that potassium and sodium concentration, etc., etc. Once we have accepted that death is inevitable, our focus shifts to the person, his physical needs, treatment of pain, breathlessness, whatever condition that is. It shifts to understanding the person, understanding his social, psychological, or spiritual needs, and satisfying them as well as possible. It is not a question of abandoning him. Let's make that very clear. We are not saying that there is nothing more we can do. We are saying that there are things to be done, not to keep your heart beating, but to keep you comfortable and have your wishes satisfied. So how do we go about it? Suppose you know that your patient with an advanced incurable illness is slowly withering away. We need to learn to diagnose impending death. This is not done only chemically, it's also done by visualizing, seeing what's happening to the circulation, seeing how the food intake is dropping, seeing how the person is even unable to swallow. You evaluate the dying process. And then we need an honest, empathetic communication with the family. Now, the problem often is we seldom communicate about diseases to the family. Not enough. And sometimes the family doesn't wish to talk about it. That's also true. But usually in every family there will be somebody or other who is prepared to face the issue, who is willing to listen to this. And I think we need to sit down with them and be as honest as possible. And we should not use euphemisms like saying things are not looking so good. What you mean is he is dying. What they understand is some correctable problem may be there. At some point, we will have to say, unfortunately, it looks like your dad is dying. Now, prior to that, it will be ideal if we already have prepared the family, but sometimes there is not enough time for that. Now, the person who is listening may start crying, may be angry, may be overcome with guilt. There will be many things. This person who is interacting with the family will need some time. Now, this is what the intensivist doesn't have usually. What he cannot find is the time. What she cannot find is the time. Therefore, we shall have to empower ourselves. In the intensive care unit that I visualize for the future, there will be a single point contact for the family of the patient. It may be a medical social worker. That's reasonable because the medical social worker doesn't get involved in nursing chores or in doing a tracheostomy. they will have time. The doctor is still needed to ask medical questions, answer medical questions. The nurse is still needed to answer nursing issues. But overall communication has to be with a single point of contact. And all of us in India, in the medical and nursing professionals, do not have formal training in communication. In the UK, a medical student will have 36 to 100 classroom hours, depending on the university, purely on communication, I am told, whereas here it's a big zero. If we treat the family with respect, with empathy, trying to understand their point of view, putting ourselves in their place, then they will open up and convey to us their fears, their questions. If we stop the ventilation, will I be killing my dad? That may be the question. And we shall have to be prepared to answer those questions. That kind of preparedness will have to be happening among the treating team. And remember, some feelings of guilt and remorse are unavoidable. Many of you may be listening and thinking about how a relative died, maybe a grandparent, maybe an uncle or aunt. And you may still, or the children may still be feeling guilty. If only I had taken there, if only I had done this. Some guilt and remorse are unavoidable. And sometimes we expect families to take decisions as if we were handing a menu in a restaurant. Look, when you go to a restaurant and the waiter hands you a menu, do you give your choice in 30 seconds? You say, let us take a look, come back in 5 minutes. You take a 5 minutes just to choose an item on the menu in a restaurant, and you expect a family member to come out with a decision on the most important decision in their life in a minute? Simply not possible. This is why I believe that in the ICU, there should be one person who has the time and willingness to spend some time with the family. And you will have to give some time. Once you say that we believe that further interventions may not be useful, once you decide that we feel for the continuing artificial ventilation of the lungs may not be helpful, you don't expect the family to take the decision immediately. So the dictum will be, whatever you are doing, you will continue till the family has had time to think about it, to ask questions, to ask doubts, and give their choice. And when you do those sessions, never, ever say, nothing more can be done. I am a palliative care doctor. I sincerely believe that there is no situation, no clinical situation where nothing more can be done. Maybe there is nothing more that can be done for a cure, but there is always something to be done to keep the person comfortable. If not, at least lay a hand on the hand and offer companionship. Now, more and more Western intensive care units are including palliative care teams in their within the team. But there is something called palliative approach. I sincerely believe that every clinician and every intensive, including every intensivist, should have a palliative approach, accepting that the clinician's duty is not only to keep chemical homeostasis and to prolong life, that the clinician's duty is also not only to cure and relieve symptoms, but also to comfort. And this option of palliative care is offered to the family. The family is not told there is nothing that can be done. The family is told maybe continuing the ventilation may not help. Instead, let us change the medication so to aiming at comfort care, so to ensure that he is not breathless, to ensure that he is not in pain, and so on. Now, both in treatment of pain and breathlessness, morphine can help. Today, there are a lot of intensive care units where morphine is not available. It becomes necessary sometimes. Now, as a postgraduate student, I was taught that the one absolute contraindication for morphine was breathlessness. Today, I would say that in very many situations, the drug of choice for breathlessness is morphine. I don't mean a large dose, but an average adult will take about 5 to 10 milligrams of morphine 6 hourly orally. Unless they are already in renal failure, then it will be 8 hourly or 12 hourly. And with that dose, the sensation of breathlessness subsides. Maybe the effect on the brain, maybe also the vasodilatation, but the sensation of breathlessness is less. And if it is pain, we will have to titrate the dose of the opioid to the degree of to pain relief. And generally, in the care, you don't do 4-hourly electrolytes anymore or blood gases. The objective of the treatment shifts to care. You may not any longer do 2-hourly change of position. You may still do it 4-hourly to ensure that the skin is intact. If there is rattling in the throat, that kind of voice, because the person is no longer able to swallow, you may use a drying agent like sodium glycopyrrolate to dry up the secretion so that the rattling stops. But it's also important to allow the family's touch and presence. Time and again, I've seen how families continue to be angry with the medical system because they were denied a final goodbye. When my time comes, please remember, I need that hand to hang on to. I need my family with me. Now, about yourself. If you are able to think about death, prepare a living will or advanced directive. Today, the law doesn't ratify it, but the Medical Council's recommendation and the Law Commission's report, the Medical Council's, it's a statutory body, their recommendations ratified. Say, as I have done in the living will, that if I find myself in an incurable situation, I would not want such and such life extending treatment. I will want palliative care instead. Now, to protect myself, I had to bring in this subject up with my wife and my children. My children initially didn't want to talk about it, but I was persistent. And they saw the reason why I was so anxious about it, to discuss it. And eventually they agreed to listen to it. This is important. And of course, if I have a regular doctor, he should also know my wishes. And I believe all of us need to accept death as the consequence of life. And we shouldn't be a death-denying society anymore. In Bhutanese culture, everyone is asked to think about one's own death 5 times a day. That keeps our feet on the ground. Death has to be a subject of conversation so that it becomes accepted by all of us. Now, if you want any of these statements, like advanced directives, sample form as given by the Medical Council of India. The second document that I show there is the position statement by Indian Society of Critical Care Medicine. If you want to look at the medical council directives or the law commission report or the recent Supreme Court ruling in the Aruna Shanbag case, which is not leaving very clear guidelines, just go to our organization's resources page on Endoflife care or write to us. I would want you all to live a long and happy life. But I would also want you to remember that we are all mortal. And once we accept our mortality, we are able to think about these things and to be prepared for it so that we don't end up getting tortured in intensive care units and so that we don't end up torturing our patients in intensive care units in the context of futile treatment. Thank you very much for listening to me patiently. I'll be very happy to take any questions.
Our first question is from Sunil. Shouldn't a person be able to say that his or her pain and suffering is too much to bear and have the right to be free of that suffering?
Internationally, there is quite a lot of agreement that access to pain relief is a human right. No, that is not spelled out in our law. In the sense we say life with dignity is a fundamental right. What dignity is there when somebody is forced to roll in pain and lose control over one's own mind over pain? So going by that and going by international consensus, access to pain relief is a human right, which is denied to 99% of people in India. This is a huge injustice. So Sunil, I entirely agree with you. This is something that we should be conscious about and we should be demanding.
Next question is from Dr. Rajesh Bhalla. How does one provide medical support at home at end of life?
Dr. Bhalla, I live and work in Kerala. Kerala has a network of palliative care centers. Many of them are within the government system because the government has a state palliative care policy, but the larger number are non-governmental. Very few are on the corporate sectors. Most corporate hospitals do not have palliative care. Now, of about 170 palliative care centers which have access to oral morphine, the majority offer home visits. In Kerala, every panchayat has a palliative care nurse who visits every bedbound patient at least once in a month. It is not hugely expensive. This is happening in Kerala. It is possible. And I believe as medical professionals, we have a duty to make that happen, not just sit in our ivory towers and see only patients who can come to us, but actually go to people who are unable to travel any longer and see them at home. For the poor, it has to be free, but for the affluent, it can be a paid service, but this has to happen, Dr. Bhalla. It is happening in Kerala to a large extent.
Next question is from Rajiv. He says, Sir, excellent content. What is your view on DNR cases?
Now, DNR, once we come to that acronym, do not, of DNR for do not resuscitate, it becomes a sensational issue. Because unless it is ratified by law, because the common man very often equates DNR to euthanasia. Unfairly, that's not correct, but it happens. See, when we use a term, we have a certain meaning in our minds. The listener has some other picture about it. So when the listener hears it as passive euthanasia, then there is a problem. The man has brought the uncle for treatment, and here the doctor says, condemn him to euthanasia. That's the message that the person is taking. So that term is a problem till the Parliament passes the proposed end-of-life care law. And let us hope that these terms are clearly defined. The Indian Council of Medical Research is taking some steps to define these terms. But Mr. Rajiv, let us use another acronym. AND, allow natural death. What we are really saying is that we should permit the person to die a natural death with dignity and not jump on his chest and do all those horrendous things when we know very well that the situation is futile. So it's a matter of semantics, like what you mean may not be what the person hears. So if I had the choice in my institution, I may write on a file that aggressive treatment will not be helpful. The matter is discussed with the family. The decision is taken that he should be allowed a natural death with comfort. That's what I'll write on the file. But when the law comes into place, let us see what they use, what terms they use, and how they define DNR.
Next question is from Mary. I understand that advance directives is not legally valid. Please clarify.
You're absolutely right, Mary. The advance directives are neither valid nor invalid. You follow me? There is no law. So how can it be legal or illegal? How can it be legally valid or non-invalid? But remember, in the absence of law, the court is likely to go by the by decisions of statutory bodies. The Medical Council's directives, which you can see on our website or on Medical Council's website, does ratify it, says that advance directives can be made and that the medical system has a duty to respect it. It is not the law, but in the absence of law, that carries a weight. But on the other hand, if the doctor wants to say, no, this is not a legal document, I will not respect it, well, that's the fluid situation that we are in now. But I do hope my doctors, I hope they will practice ethical medicine, and even if there is no law, I hope they will respect my wishes, because I have autonomy over this body more than the doctor with all the degrees.
Next question from Sanket. How to create awareness about discussing death and end of life among community when even doctors are not aware of this concept?
Sandeep, you said when even doctors are not aware of this concept. But you will find that the problem is more with doctors refusing to think about it. The average man on the street is less afraid of death. For the doctor, death means a medical failure. The man on the street is not like that. One of my colleagues wrote an article in the Hindu. Her name is Jeena. Jeena says she was reading Atul Gawande's Being Mortal, that rage of a book. And as she was reading it, she just talked to her mom and said, Mom, when I die, I don't want this and this and this. I want that and that and that. And she says, the mother spontaneously responded, saying, I agree. I also do not want this and this and this. I want that and that. I mean, then she went to her dad and said the same thing. So it was such a natural thing for many people to talk about, except for doctors. But not everybody. The children who have grown up in nuclear families have never seen death. people of my generation grew up seeing that, seeing the cattle dying in the shed, the grandparents dying. That luxury is not there. So death has become a stranger. So it will be necessary to raise discussions on this, for more newspaper articles on this. And the Elizabeth Kubler-Ross Foundation had promoted a program recently. It says, let us have dinner and talk about death. I mean, death shouldn't be the stranger it is. And to you, the questioner, I would say, if you are part of a club, a society, an organization, make it the subject of talk. This subject discussion is needed if we are to avoid needless cruelty to the dying, and if we are to avoid total impoverishment of families because of unnecessary infliction of very expensive treatment which destroys families.
Next question from Dr. Rajesh. Is DNR being considered by MCI or Parliament, or are we awaiting for PIL to be initiated on this issue, as this is a long-standing decision?
Rajesh, the MCI already has guidelines on this. You can see it on our either on Medical Council's website or on our website. It is there. The Medical Council already has a directive. What is not there is a law. No, PIL unfortunately now will not work because in the Aruna Shanbag case, there was a certain judgment and then there was a review petition, and recently the Supreme Court said, let the People's Parliament decide. And when they went with another review petition, the Supreme Court did not entertain it. They said, this is a matter for the Parliament to decide. A law has to be enacted. Following this, in 2016, the government posted on its website a draft law for protection of the terminally ill. I mean, there were many problems with that, and many organizations, and we also have responded, pointing out the problems and saying what corrections are needed. So I do hope that it will happen, because the Supreme Court has asked the Parliament to do it, and many people feel that it is necessary. So another PIL is unlikely to work, public interest litigation is unlikely to work, because the matter is in the court of the Parliament.
Next question from Dr. Suman. How much have we progressed with regard to patient-friendly ICUs in South India?
Suman, very little is my answer. Now, actually, only about 5 days back, several experts in intensive care were together in Bangalore discussing specifically this problem. This was a meeting of the so-called ELICIT program, that is a coalition between the Indian Society of Critical Care Medicine and the Indian Association of Palliative Care, and I was a part of that meeting. And one of the matters that we discussed was that we should promote the concept of patient-friendly ICUs. That the focus in those ICUs, the focus will not only be the disease and the chemistry and the oxygen saturation, the focus will be on the human being and the family. So this is being discussed. I do believe that many Western ICUs are much more patient-friendly than our torture chambers. The movement is starting. But as Rajiv earlier asked, unless there is public awareness and public demand, the change may take too long. But it's very early days for patient-friendly ICUs.
Taking our last question from Rajiv. After taking decision of stopping treatment with next to kin, can other family member will lodge a case? Or to doctors will be liable?
Rajiv, there is absolutely nothing that can protect against litigation. Litigation is always possible. What we can be protected against is only against conviction. Now, if the next of kin has given the agreement and we have documented it properly, we should be reasonably safe, but still somebody can go to court with a civil suit or with a or to the consumer court. They have the right to go. Now, this is a matter of difficulties for us, but let me also tell you, now the other thing is starting. Only about 3 weeks back, there was a Western case where a family went to court alleging that there was unnecessary effort at prolonging life causing intense suffering for the patient. So either way the litigation can happen. But very clearly the next of kin has the right and somebody else going to court is unlikely to win.